You know that feeling? A simple stomach ache, something you'd probably just brush off. But what if that vague, dull pain right in the middle of your gut is actually the first warning shot for one of the most common surgical emergencies in the world? Okay, let's dive right into the urgent and pretty fascinating story of acute appendicitis.
I mean, just look at that number, 7 to 8%. That means almost 1 in every 10 of us will deal with this at some point. So this isn't just some obscure medical condition. This could genuinely affect you or someone you love. It's not rare at all. It's a remarkably common crisis.
And that's the big question, right? That's the mystery we're going to unravel today. We're going to follow the clues, piece by piece, from that very first subtle feeling of pain all the way to the critical decisions that can literally mean the difference between a quick recovery and a major, life-threatening problem.
So you'd think if appendicitis is so common, why does it still trip people up? Why is it so dangerous? Well, the answer is pretty simple. It's a master of disguise. It doesn't always show up with bright flashing lights and a loud alarm bell.
And what makes it so tricky is how all these things can pile up. It starts with those really vague symptoms, so naturally people wait it out, thinking it's just indigestion or something they ate. Then you have groups like the elderly or people with diabetes, where the body's warning system can be much, much quieter. It's really a perfect storm of being both subtle and incredibly serious.
All right, to really understand how doctors figure this out, you have to follow the pain's journey. And it's not random at all. It's a very logical step-by-step biological chain reaction. Okay, so it all kicks off with a simple blockage. Usually it's just a tiny, hard piece of stool called a fecalith. Now, with the exit blocked, mucus starts to build up, and the pressure inside the appendix just skyrockets. This pressure gets so high, it actually squeezes the blood vessels shut, cutting off the blood supply. The tissue starts to die. And finally, that swollen, angry appendix starts to irritate the actual lining of the abdomen. Every single step changes how the pain feels.
And this is the aha moment. This is the result of that whole chain reaction. The first kind of pain, the visceral pain, comes from the appendix itself stretching. Our brains are actually not very good at pinpointing pain from our internal organs, so we just feel it as this vague ache around the belly button. But once that inflammation touches the wall of the abdomen, which is packed with very specific nerves, the pain transforms. It becomes sharp, easy to point to, and that's what we call somatic pain.
So this brings us to the single most important clue in the entire story: migratory pain. That journey, that classic pattern of pain starting in the middle of the belly and then moving down to the lower right side, that's the body's way of telling us exactly what's happening. It's the smoking gun.
But what happens if nobody intervenes? Well, the pressure just keeps building and building until the wall of the appendix can't take it anymore and it bursts. This is the moment when everything changes and the clock starts ticking much, much faster.
So once that appendix perforates, there are really two ways things can go. In the best-case scenario, the body's own emergency response team, this fatty tissue called the omentum, races over and wraps itself around the leak, walling it off and creating a contained pocket of infection, an abscess. But if that fails, the infection spills out everywhere, spreading throughout the entire abdominal cavity. That's called generalized peritonitis, and it is an absolute life-threatening emergency.
Now this is one of the most important things to take away from this whole explainer. You'd think a burst appendix would cause unbelievable, off-the-charts pain, right? Well, that's a really dangerous assumption to make.
And here's why. For some people, especially the elderly and those with diabetes, the body's alarm system, that inflammatory response, is kind of turned down. They might not get a high fever, they might not be in agony, even when their appendix has already burst. They can be incredibly sick, but without any of the classic dramatic signs, which means doctors have to be extra vigilant.
So with all these vague and sometimes misleading clues, how do doctors actually crack the case? Well, it's a mix of good old-fashioned detective work and some seriously cool modern technology.
One of the classic tools is this, the Alvarado score. Think of it like a diagnostic checklist. Doctors go through and assign points for different things, like, does the patient have that migratory pain we talked about? Yep, that's a point. Have they lost their appetite? Another point. And of course, there are two big points for tenderness when the doctor presses on that lower right abdomen.
It's actually a pretty simple but surprisingly effective system. Now, getting a score of 7 or higher doesn't mean it's 100% appendicitis, but it tells the doctor that the probability is super high, and it's time to bring in the big guns for confirmation.
And those big guns are usually a CT scan. This lets doctors literally see the appendix. They're looking for telltale signs.
Is it swollen? Is the wall thickened? They also look for something called fat stranding, which is basically just a visual sign of inflammation in the fat around the appendix. And, most importantly, the scan can spot complications, like an abscess or even tiny bubbles of air outside the appendix, a dead giveaway that it has perforated.
So once the diagnosis is confirmed, what's next? The treatment plan isn't one size fits all. The right path depends completely on how far along the disease has progressed.
All right, scenario 1, the best case scenario. It's caught early, the appendix is inflamed but hasn't burst. The path here is crystal clear. The patient heads straight to the operating room for an immediate laparoscopic surgery to get it out. It's minimally invasive, recovery is usually fast. This is the outcome we're all hoping for.
But what if the body has already done its job and walled off the infection into an abscess? Well, rushing in to operate can actually be risky because everything is so inflamed and stuck together. So often, the smarter move is to treat the infection first. A radiologist will drain the pus, the patient gets strong IV antibiotics, and everything is allowed to cool down. The surgery to remove the appendix might happen weeks later, once things have calmed down.
And then there's the most dangerous scenario. If that infection has spread everywhere, there is zero debate. There is no waiting. This is a 5-alarm fire, a life and death situation that requires emergency surgery, right now, to get the appendix out and wash out the entire abdomen. It is an absolute, non-negotiable, life-saving intervention.
Wow, so we've gone all the way from a simple ache to a really complex set of medical decisions. So what are the biggest lessons here? What are the key things to remember from this whole journey?
Let's do a quick recap. First, that migratory pain is the classic textbook sign. Second, always be extra cautious when an elderly or diabetic patient has abdominal pain because their symptoms can be dangerously quiet. Third, modern imaging like CT scans has been a total game changer, preventing countless unnecessary surgeries. And finally, and maybe most importantly, every single hour of delay matters. And really, this final thought says it all. Appendicitis is quite simply a race against time. That journey from a simple, easily treatable inflammation to a complex, dangerous, widespread infection is measured in hours. Understanding that race and respecting it is the absolute key to navigating the world's most common surgical emergency.